Most people over 65 assume that more blood tests automatically means better health care. Your doctor orders a panel, you get it done, and you feel like you are being thorough and responsible. And in many cases, that is absolutely true. But here is the part that almost no one tells you, and it is something I see cause real harm to real patients on a regular basis. Some blood tests, when ordered for the wrong person at the wrong time, do not just fail to help you. They can actually set off a chain of events that leads to unnecessary procedures, unnecessary medications, unnecessary anxiety, and in some cases, genuine physical harm from follow-up testing that was never actually needed. By the way, I am a board-certified physician, and today I am going to walk you through the 7 blood tests that, after the age of 65, I would think very carefully about before agreeing to have done, what the risks of each one actually are, and most importantly, what to ask your doctor so that you can make an informed decision about your own health. Now, before I get into the list, I want to be very clear about something. I am not telling you to refuse testing. I am not telling you that these tests are never appropriate. What I am telling you is that after 65, the risk-benefit calculation for certain tests shifts in ways that most patients are never told about, and that knowing these things makes you a more empowered, better protected patient. That is what today is about, so let's get into it, starting with number 1. The first test I want to talk about is the PSA test, which stands for prostate-specific antigen, and it is used to screen for prostate cancer in men. Now, at first glance, screening for cancer sounds straightforwardly good. Find it early, treat it early, save a life. That is the intuitive logic. But here is the reality that the data shows, and it is a reality that the United States Preventive Services Task Force, the American Cancer Society, and numerous other major medical bodies have spent years wrestling with. PSA levels naturally rise with age. After 65, a significant portion of men will have an elevated PSA reading, not because they have dangerous prostate cancer, but because of benign prostatic hyperplasia, which is a non-cancerous enlargement of the prostate that is extremely common in older men, or because of inflammation, infection, or simply age-related changes in the gland itself. An elevated PSA, in other words, does not mean cancer. It means follow-up, and follow-up typically means a prostate biopsy. Here is where the harm comes in. Prostate biopsies carry real risks. Infection, bleeding, urinary symptoms, and in some cases serious complications requiring hospitalization. And what do biopsies often find in older men? They find low-grade prostate cancers that grow so slowly they would never have caused any symptoms or shortened life in any meaningful way. These are cancers that pathologists sometimes describe as something a man would die with, not from. But once a cancer is found, the psychological and clinical pressure to treat it is enormous. And treatment for prostate cancer, including radiation and surgery, carries its own significant risks, including urinary incontinence and erectile dysfunction that can dramatically reduce quality of life. A landmark study published in the New England Journal of Medicine, the Preventive trial, which followed over 1,600 men with localized prostate cancer for a decade, found that active surveillance, meaning careful monitoring without treatment, produced survival outcomes comparable to surgery or radiation. The cancer in many cases did not need to be treated at all, but first you had to find it. And finding it started with a PSA test. The solution here is a direct conversation with your doctor. Ask specifically, given my age, my overall health, and my life expectancy, what is the actual chance that finding prostate cancer through this test would change my treatment or my outcome in a meaningful way? That conversation, with honest answers on both sides, is worth more than any number on a lab report. The second test I want to talk about is the CA125 test, which is a blood marker used to detect ovarian cancer in women. And I want to be very direct with you here because this one surprises a lot of patients when they hear it. CA125 is a protein that can be elevated in the blood when ovarian cancer is present. Sounds like exactly the kind of thing you would want to screen for, especially since ovarian cancer is known for being difficult to detect at early stages. The problem is that CA125 is not specific to ovarian cancer. It can be elevated by endometriosis, uterine fibroids, pelvic inflammatory disease, liver disease, and even simply menstruation in women who are still cycling. But after 65, those reproductive causes are less common, so you would think the test would be more reliable. In fact, the opposite problem dominates. In postmenopausal women over 65, CA125 can be falsely elevated by benign conditions, including benign ovarian cysts, which become more common with age, as well as gastrointestinal conditions and general inflammatory states. A false positive on a CA125 test leads to ultrasound, and if the ultrasound is inconclusive, it leads to surgery. And exploratory pelvic surgery in a woman over 65 carries real anesthesia risks, real recovery challenges, and real potential for complications. The United States Preventive Services Task Force currently recommends against CA125 screening for ovarian cancer in women who are not at high genetic risk, meaning women who do not carry BRCA1 or BRCA2 mutations or have a strong family history, precisely because the harms of false positives in average-risk women outweigh the benefits of the screening. This does not mean the test has no place in medicine. It means it has a specific place for specific women under specific circumstances, and broad routine use in women over 65 without elevated genetic risk is not supported by the current evidence. If your doctor recommends this test, ask, am I at elevated genetic risk for ovarian cancer? If the answer is no, ask what the evidence says about screening in women at average risk at my age. Number 3 on the list is one that surprises a lot of my patients, and that is the thyroid cancer screening panel, which is sometimes ordered as part of a general wellness blood panel or driven by the finding of a thyroid nodule on imaging done for another reason entirely. Here is the reality of thyroid cancer in older adults that most people are never told. Thyroid cancer is one of the most common cancers found on imaging and on autopsy in older adults. Studies examining the thyroids of people who died from other causes have found unsuspected thyroid cancers in between 5 and 36% of individuals, depending on the study. The vast majority of those cancers were small, slow-growing, encapsulated, and had caused no symptoms and would never have done so. This phenomenon is so well recognized in medicine that it has contributed to a significant shift in how thyroid nodules are managed. In the past, any nodule that was found would be biopsied, and any cancer that was found would be removed. Today, major guidelines from the American Thyroid Association recognize that many small, well-defined thyroid cancers in older adults, particularly papillary microcarcinomas, are appropriate candidates for active surveillance rather than surgery. The surgery for thyroid cancer, thyroidectomy, carries risks including damage to the recurrent laryngeal nerve, which controls the voice, and damage to the parathyroid glands, which regulate calcium, leading to potentially permanent hypoparathyroidism. The question is not whether the cancer can be found. In older adults, the question is always whether finding it will change the outcome, and whether the intervention it triggers will do more good than harm. If a thyroid cancer screening is recommended after an incidental imaging finding, ask your doctor. Is this a nodule that requires biopsy based on its size and characteristics, or is observation appropriate? And if biopsy reveals a small, low-grade cancer, ask specifically about active surveillance before agreeing to surgery. The fourth test on my list is something that is ordered extremely commonly in older adults and that generates an enormous amount of follow-up anxiety and follow-up testing, and that is the CEA test, which stands for carcinoembryonic antigen, used as a marker for colorectal cancer and several other cancers. Here's the problem with CEA as a screening tool in seniors, and I want to be precise about this. CEA is a useful marker in very specific contexts. If someone has already been diagnosed with colorectal cancer and treated, monitoring CEA over time can help detect recurrence. That is a legitimate evidence-supported use of the test. But using CEA as a general screening tool to look for cancer in an older adult who has no known cancer is a different matter entirely. CEA levels are elevated by smoking. They are elevated by chronic lung disease. They are elevated by inflammatory bowel disease, liver disease, and pancreatitis. They are elevated by benign conditions that are extremely common in people over 65. In older adults, the baseline rate of mildly elevated CEA from non-cancerous causes is high enough that a positive result sends a significant number of patients down a path of CT scans, PET scans, colonoscopies, and biopsies looking for a cancer that is not there. Research published in the Annals of Internal Medicine examining the performance of tumor markers like CEA in unselected populations has consistently shown that the positive predictive value, meaning the probability that a positive test actually indicates cancer, is low when the test is used in individuals who do not have specific clinical symptoms or a prior cancer diagnosis. In plain terms, a lot of positive results are false positives, and false positives in a 70-year-old are not free. They cost time, money, physical discomfort, radiation exposure, and significant anxiety. If CEA is recommended to you as a screening test and you do not have a prior diagnosis of cancer, ask your doctor what specific clinical indication is driving this recommendation and what the expected positive predictive value of the test is in someone with your clinical profile. Number 5 is one that I feel particularly strongly about, and that is whole body or multi-cancer early detection blood panels, sometimes marketed directly to consumers as a way to screen for dozens of cancers simultaneously with a single blood draw. These tests have become increasingly available and increasingly popular, and I understand the appeal completely. The idea of catching any cancer early with one simple test is genuinely attractive, but here is what you need to understand before you spend money on one of these panels or before you agree to one that is offered to you. Multi-cancer early detection tests, sometimes called MCED tests, work by detecting cell-free DNA or protein signals in the blood that may be shed by tumor cells. The technology is genuinely impressive and has real potential, but the clinical evidence for how to act on the results in older adults is not yet mature, and this is important. When one of these tests comes back positive for a possible cancer signal in one of the 50 or more cancer types it screens for, the follow-up burden can be enormous. Because the test does not tell you exactly where the cancer is, finding the source of the signal can require a full-body imaging workup, scopes, biopsies, and a cascade of procedures, each carrying its own risks. In older adults over 65, the likelihood of having an incidental finding somewhere in the body, meaning something that looks abnormal on imaging but is benign or clinically insignificant, is very high. Chasing those signals through an older body with multiple comorbidities, reduced physiological reserve, and greater sensitivity to procedural complications is a very different risk calculation than chasing them in a 45-year-old with no other health conditions. Major medical organizations, including the United States Preventive Services Task Force, have not yet issued a recommendation in favor of MCED screening for the general population because the evidence that these tests reduce cancer mortality in real-world use, as opposed to laboratory performance, is still being gathered. That does not mean they will never have a role. It means that right now, the honest answer about their benefit in routine senior screening is that we do not yet fully know. If you are interested in one of these panels, the conversation to have with your doctor is, what is the plan if this test comes back positive? Who will coordinate the follow-up? And am I in good enough overall health to go through the cascade of testing that a positive result will likely require? Test number 6 is one that I see create problems specifically in seniors who are being proactive about bone health, and that is the PINP and CTX bone turnover markers panel, which is sometimes ordered alongside or instead of a DEXA scan to assess bone loss. These markers, PINP, which stands for procollagen type 1 N-terminal propeptide, and CTX, which stands for C-terminal telepeptide, are proteins released into the blood during bone formation and bone breakdown, respectively. They are genuinely useful tools in specific clinical contexts. If someone is already on osteoporosis treatment, measuring these markers over time can help assess whether the treatment is working. That is a legitimate use. But using these markers to diagnose or screen for osteoporosis in the first place, rather than using a DEXA scan, creates a specific problem in older adults. Bone turnover markers are highly variable. They fluctuate based on the time of day the blood is drawn, whether the person exercised recently, whether they have been immobile, whether they have a vitamin D deficiency, whether they have kidney disease, and a dozen other factors that are common in seniors. A single measurement of PINP or CTX in an older adult can look alarming and drive decisions toward medication when the underlying DEXA scan, the actual measurement of bone density, would tell a more nuanced and reassuring story. Osteoporosis medications, particularly bisphosphonates, are powerful drugs with real side effects, including the rare but serious condition of osteonecrosis of the jaw and atypical femoral fractures with long-term use. Starting them based on an elevated bone turnover marker without a confirming DEXA scan is, in my opinion, getting the clinical sequence backwards. If bone health is a concern, the place to start is a DEXA scan. If you are already on osteoporosis treatment and your doctor wants to monitor the response, bone turnover markers are a reasonable adjunct. But as a standalone screening tool in seniors, they are not reliable enough to drive major treatment decisions alone. The 7th and final test on today's list is one that requires the most nuance to explain, and I want to take the time to do it properly because I think this one is genuinely misunderstood. That test is the hemoglobin A1C, used to measure average blood sugar over approximately 3 months and widely used to screen for and diagnose prediabetes and diabetes. Now, let me be very clear. Hemoglobin A1C is an extraordinarily valuable test for many people. For adults with diabetes or at high risk of developing it, regular A1C monitoring is essential, and I would never suggest avoiding it. But here is the specific issue I see arise in seniors, particularly those in their mid-70s and beyond. Current clinical guidelines, including those from the American Diabetes Association and the American Geriatric Society, explicitly recognize that aggressive blood sugar targets in older adults, targets that are entirely appropriate for a 50-year-old, can actually cause harm in a 75-year-old. Here is why. Treating an older adult aggressively to achieve a low A1C below 7%, for example, increases the risk of hypoglycemia, meaning blood sugar drops dangerously low. In a younger adult, hypoglycemia is unpleasant but usually manageable. In a 75-year-old, A hypoglycemic episode can cause falls, which cause hip fractures, which in older adults carry a staggering 1-year mortality rate of approximately 20 to 30%, according to data published in the Journal of Bone and Joint Surgery. Additionally, hemoglobin A1C can be falsely low in older adults who have certain types of anemia, specifically iron deficiency anemia or hemolytic anemia, which are not uncommon in seniors. A falsely low A1C in a senior with unrecognized anemia can create the misleading impression that blood sugar control is better than it actually is, delaying appropriate intervention. The problem is not the test itself. The problem is when the result is used to set the same targets and drive the same treatment decisions in a 78-year-old that it would in a 50-year-old. The American Geriatric Society's Beers Criteria, which is a widely respected guide to medications and clinical practices that carry increased risk in older adults, specifically flags tight glycemic control in older adults with multiple comorbidities as a practice to approach with caution. If A1C testing is part of your care, the conversation worth having with your doctor is this: given my age and my overall health, what A1C target is actually appropriate for me, and what medications would be used to achieve it, and what are the hypoglycemia risks of those medications, all right? Let me bring this together with a quick recap of all 7, because I know that is a lot of information and I want to make sure it is clear. Test number 1, PSA screening in men over 65 without specific risk factors or symptoms, because it frequently leads to biopsies and treatment of cancers that would never have caused harm. Test number 2, CA125 screening in women over 65 who are not at elevated genetic risk for ovarian cancer, because false positives lead to surgery in a population where surgical risk is significant. Test number 3, aggressive thyroid cancer workups driven by incidentally found nodules, because small thyroid cancers in older adults are common, often clinically insignificant, and the treatment carries real risks. Test number 4, CEA, used as a general cancer screening tool in seniors without a prior cancer diagnosis, because the false positive rate in this population drives unnecessary and potentially harmful follow-up testing. Test number 5, multi-cancer early detection blood panels before there is a clear plan for how to act on a positive result, given the cascade of follow-up testing a positive can trigger in an older body. Test number 6, PINP and CTX bone turnover markers used in isolation to diagnose osteoporosis or drive treatment decisions without a confirming DEXA scan because of their high variability and the consequential nature of the medications they might prompt. And test number 7, hemoglobin A1C interpreted and treated to the same targets in a 75-year-old as in a 50-year-old, because aggressive glycemic control in older adults increases hypoglycemia risk, and hypoglycemia in seniors increases fall risk with potentially life-altering consequences. None of this means refusing care. None of this means distrusting your doctor. It means showing up to your appointments as a partner in your own health decisions, asking the right questions, and understanding that in medicine after 65, more is not always better. The right test at the right time for the right person is what good medicine actually looks like. If you found this useful, and I genuinely hope you did, I want to point you towards something else that I think every senior and everyone who loves a senior should watch. Click on the next video to learn about the 5 most common medication mistakes that doctors see in patients over 65, the ones that go unnoticed for months and cause the most damage, and exactly what to do to protect yourself. I will see you there.